Hello friends. So this video is regarding how to read a chest X-ray. This is our second video in the pediatric radiology series, and this is also the second video in the table viva series. So if you have not watched those two videos, please do watch those as well. So today we will learn a very systematic approach how to read a chest X-ray, and we have a mnemonic for that. So the mnemonic is called DRABCDEF or Dr. ABCDEF, where the D stands for the date and the data of the patient. The R stands for RIP, where we look at the rotation, degree of inspiration, and the penetration. A stands for airway. B stands for breathing, which includes lung fields and the pleura. C stands for circulation, which includes heart and the blood vessels. D stands for diaphragm. And finally, the E stands for everything else, which includes your soft tissues, the bones, the lines, the catheters, and everything else. So the first thing one should look in a chest X-ray is the date and the data of the patient. So whenever you get X-ray in your hand, you should confirm that it belongs to the right patient. Right? So you have to look at the name and the details of the patient. Also look at the date of the patient, because some patients can have multiple X-rays, and it helps in sequentially arranging the X-rays and see what is going on with the patient. Right? The radiographer usually places a marker on the X-ray to tell you which side is which. Another important thing which determines quality of a X-ray is the rotation. So a degree of rotation can seriously affect the quality of a chest X-ray. Right? For example, if the patient is rotated in a supine position, so the side which is down will appear more hyperlucent, and the side which is up will appear larger in size. And also there will be an apparent cardiomegaly. So it becomes very difficult to interpret these images whenever there is even a slighter rotation. So look at this X-ray, right? So how will we know whether it is rotated or not? So we have to look at the spinous processes. So these are the spinous processes of the vertebral column. So whether they are in midline or not. And then from these spinous processes, we see whether the medial end of the clavicle is equidistant or not. So we can see that on the right side, it is nearer to the spinous processes, while on the left side it is further away. So this X-ray film has a slight degree of rotation in it, right? So you can see these are the spinous processes. Left clavicle is further away, right clavicle is nearer to, so the patient is rotated. So if you calculate the CT ratio in this patient, it will come out to be 53%, which is suggestive of cardiomegaly. Now what we did, we repeat the X-ray without rotation in this patient. So now you can see the spinous processes are now more in midline and the clavicles are now equidistant. And now if you calculate the CT ratio, it will come out to be 47%. So image interpretation will become very difficult, and you will wrongly interpret the signs if there is degree of rotation is present in X-ray film. Another thing which determines the quality of an X-ray, chest X-ray especially, is the degree of inspiration. So ideally, the diaphragm should be intersected by the 5th to 7th anterior ribs in the mid-clavicular line. When it is less than 5th expiratory film, we call it expiratory film. If it is more than 7 rib, then we call it hyperinflation. So you can see in this X-ray, in the mid-clavicular line, only 3 anterior ribs are visible. So it's an expiratory film. And the opacity you are seeing in this X-rays, right? You can see that this area appears to be more opaque, right? So someone may falsely interpret as a consolidation, which is not the case. When the X-ray is repeated in this patient with a good degree of inspiration, you can see now how many ribs: 1, 2, 3, 4, 5, and 6, right? So 6 anterior ribs are there cutting the diaphragm in the mid-clavicular line. So 5 to 7 is our cutoff. Less than 5 is expiratory film, and more than 7 is definitely inspiratory film. More than 7 is in hyperinflation. So now you can see that that consolidation has disappeared, right? So whenever there is an expiratory film, the heart will appear larger in size and there will be apparent cardiomegaly. And also in the basal region, you can see some radiopaque shadows which may not be there in actual. Another thing which determines the quality of X-ray is the penetration, right? Whether you have given high dose of radiation or very low dose of radiation. So X-ray film may appear too black or too white depending upon the dose of radiation. Ideally, the vertebral bodies and more precisely the intervertebral disc should be just visible behind the heart. Another point which you can make a note of is that left hemidiaphragm should be visible up till the spinous process. If it is not visible, then it is an underexposed film, right? So let us look at the different example, whether it's an underexposed film or an overexposed film. So this film, we cannot make distinct vertebral bodies and intervertebral discs are not visible at all. So it's an underexposed film. So it appears more white, right? On the other hand, this is an overexposed film, so everything appears too black, right? You can easily make out vertebral bodies and intervertebral discs are clearly visible as a black line. This, on the other hand, is a correctly exposed film, right? So this is the right exposure. This is what we want. So neither underexposed nor overexposed. Okay, so now we have, up till now we have determined the quality of an X-ray, whether our X-ray is done correctly or not, whether the degree of penetration is right, whether there is any rotation which is there or not, whether the patient has taken right amount of inspiration. Now we come to what all we have to analyze in the X-ray. So the approach for that is A, B, C, D, E, F. In the A, it comes to the airway. In the airway, we specifically look for tracheal deviation, whether there is any airway narrowing, and we also look at the carinal angle. Normally it should be less than 105 degree. So this is how typically an airway looks in an X-ray. So mainly we can visualize just trachea in the right and left main bronchus. So in these X-rays you can see different types of airway anomalies. In the first X-ray, the trachea is there but it is shifted towards the right side, right? So something has caused tracheal deviation. What is there, we will see further in our next slides. So in second X-ray, there is a narrowing of the airway, right? The airway appears to be narrow, which can happen in the case of acute laryngotracheobronchitis. So this sign is also called steeple sign because it gives an appearance of a steeple of a church, right? In the third X-ray, yes, obviously you may have make a note of a cardiomegaly, but you can also see that carinal angle is widened, which can appear in the left atrial enlargement. So there is widened carina. So whenever you are looking at airway, look at the carinal angle, look whether it is narrowed or not, and also look whether it is displaced or not. The second thing which come in approach is the breathing, right? So in the breathing, what you all have to look at is lungs and the pleura. So for theoretical purpose, we divide lungs into zones, right? So upper zone, middle zone, and the left zone. But remember, these are just for the radiological purposes. These do not equate to lung lobes. Lung lobes are anatomically different. These are just the zones. So as to categorize in which zone any abnormality is there, right? So once you are looking at these zones, you have to compare each zone between the lungs, noting any asymmetry, right? Second thing, apart from the lung fields, which you look in the breathing is the pleura. So pleura are usually not visible until they are very thickened. What makes pleural visible is the fluid or the blood accumulation in the pleural spores, which can result in an area of increased opacity. You should also look at the cardiophrenic angle. So you look at the CP angle. So here the CP angle is not acute, it is blunted in this X-ray. So it means that there is a slight fluid collection on the left side. Air can also accumulate in the pleura, which can give rise to pneumothorax. So here you can see that this is a typical costophrenic angle, which is an acute angle. On the other side, if you look at the left side, this angle is blunted. Now, whenever you see opacities on the chest X-ray, right, opacities can be because of different reasons. So if you look at the first X-ray, there is an opacity. Where is the opacity? Whole of the hemithorax, the whole left side is opaque, right? But also look at the mediastinum. Where is the trachea going? Trachea is going to the opposite side. So something is pushing the trachea, right? So what can push the trachea, which also looks opaque? What can appear opaque? Fluid appears opaque on the fluid appears white on a chest X-ray. Air appears black, you can see airway, you can see lung field. So air is appearing black, fluid is appearing white, so there is fluid here which is pushing. So what could be this be? This is pleural effusion. Now look at the second X-ray. Again, there is an opacity, but mediastinum is not shifted. So what can be this opacity? This is definitely not fluid, because if it has been fluid, the trachea has been shifted to, should have been shifted to opposite side. It cannot be collapsed also, because then the trachea would have shifted to same side. So trachea is not shifted. So this is consolidation. Another important feature of a consolidation is that you can see air bronchograms, right? So you can see these are the air bronchograms present in the consolidation. So these are the air bronchograms. While if you look at the third X-ray, again homogeneous opacity, but the trachea is now shifted towards same side. So there is a collapse or atelectasis which is giving rise to these opacity. So if you look at the first and the third X-ray, they appear very similar. So you may get confused that this is a pleural effusion, but no. Has this been a pleural effusion, the trachea should have shifted to right side. So in the exam, if somebody asks you, you have to describe the X-ray, and then if somebody asks you what is your interpretation, what it could be, and you have to say, sir, because the mediastinum has shifted toward the same side, it means that there is a collapse on this side. Now another important, the next in the approach is cardiac. So C for cardiac, A, B, C. I have made already a detailed video on how to interpret the cardiac structure on the chest X-ray. You can go and watch that video. But just for the completion purpose, I will tell you the most important thing which to look in a chest X-ray is the heart size. So we have to determine what is the CT ratio, right? So CT ratio, how do we calculate CT ratio? You draw a line passing through the spinous processes, so a midline, and then you calculate A and B. A is the distance further from the toward the right side, and B is the distance further away from this midline to the left side, and then you take maximum internal diameter of the thorax. If you calculate A plus B divided by C, that is your cardiothoracic ratio, right? So if this cardiothoracic ratio is more than 0.5, then it means there is cardiomegaly. However, in newborn, we take a ratio of more than 0.6 suggestive of cardiomegaly. So cardiomegaly always represent volume overload, not pressure overload, right? That is when the volume overload, when your chambers enlargement happen. But cardiomegaly can also occur because of collection of fluid around the heart, that is pericardial effusion. And we have already learned that if it is an expiratory film or a flat chest, then there is an apparent cardiomegaly, not true cardiomegaly. The next in approach is the D, that is diaphragm. So we look at the diaphragm. We have already discussed some part of it, that we have to look for the costophrenic and the cardiophrenic angles, and this costophrenic angle should be clearly visible as a well-defined acute angle, right? So obliteration of these angles can happen in the pleural effusion, like we saw in the previous X-ray as well. But sometimes even in the hyperinflation, these angles become slightly obliterated or become obtuse, right? So in a case of asthma or COPD, these angles may also become obtuse. E stands for everything else. You have to look for the bones, you have to look at the soft tissue shadows, and you have to look at all the lines and catheters. So in this X-ray, you can see so many lines and other things are also there. So you can see that there is an endotracheal tube in situ, and you can also see that there is a feeding tube reaching in up till the stomach, and you can see there are two radiopaque lines which are there, which are nothing but the umbilical venous catheter and umbilical arterial catheter. You can also see that there is a temperature probe being attached to the patient. You can also see there are some other wires are also going. So these are above the patient and not inside the patient. So these are probably the ECG electrodes which are being placed on the patient. So you have to take care, you have to take into account these all the lines and catheters which are visible on the chest X-ray. Now, whatever we have read till now will help you in interpreting X-rays in adult as well as children. There are some peculiar feature of pediatric X-rays, like, so which way I will tell you. So you commonly see in a young infant this kind of shadow. So this is not mediastinal widening, but this is the thymic shadow, or because of the thymus, right? So this smooth bordered shadow which you see in the upper mediastinum is because of thymus, right? So this is quite normal. This is also called as sail sign because it appears as a smooth sail, right? So the smooth wavy margin, this structure is a thymus. So it can appear either on the left side or on the right side, but there is nothing to be worried about. If it has a smooth margins, it is appearing in the upper mediastinum, it is most likely thymus and nothing needs to be done. Now what happened is that in table viva we show you multiple x-rays, and a student is expected to answer what he is seeing on those x-rays and give his interpretation. So even though you know the approach, you know you have to look for this, whatever that is an AP view, PA view, what is the degree of penetration, what is the degree of rotation, but it's a total different ball game when you are appearing in viva, right? So you don't have to be nervous when you are interpreting a chest x-ray. There are usually two components when you are giving your reply in the viva. You have to describe the physical attribute, what you are actually looking at the x-ray, what you are actually seeing. So whether you are finding some opacity, some hyperlucency, that you have to describe. And the second thing you have to describe is what is the likely pathology and what could be the probable diagnosis, right? So then it becomes a complete interpretation of the x-ray. So I am going to show you multiple x-rays, very easy x-rays, but these are very commonly placed in the table vivas, right? So what you will do is that you pause the video for 10 seconds, write down what you are going to answer in the exam for that kind of x-ray, and then write the diagnosis, and then resume the video to see that whether you have made a correct choice or not, right? So let's begin. So this is the first x-ray. This I have shown you already. Oh, so what will you say in the exam? So what is abnormal in this x-ray? We can see that there is an opacity on the left side. Where is that opacity? What kind of opacity it is? It's a homogeneous opacity. Now, where is it? Is it in some particular zone, upper zone, middle? No, it's coming complete left hemithorax. So it's on left side. It's occupying complete left hemithorax. And then there is a deviation of trachea to the right side. So if you describe this x-ray, this is a chest x-ray showing homogeneous opacity on the left hemithorax with deviation of trachea to the right side. Most likely this is because of pleural effusion, which is left-sided pleural effusion. Good. Another x-ray. You can pause the video and make your interpretation, right? So what is in this x-ray? Again, you are seeing an opacity. Where is that opacity? Right upper zone. With kind of opacity? Homogeneous opacity. So homogeneous opacity on the right side in the upper zone. There is no mediastinal shift, and you can see air bronchograms, right? So you can see air bronchogramming this homogeneous opacity. So it is suggestive of right side consolidation. Another x-ray. Now, what is the abnormality in this x-ray? Yes. So different kind of opacities are there. So you can see that opacities are widespread. That is not homogeneous opacity. You can see opacities here, 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 even on the left side, here, here, right? So these are heterogeneous opacities where bilateral lung fields. So heterogeneous opacity, bilateral lung field, more so in the upper zones in bilateral lung field, and no mediastinal shift. So most likely because of the pneumonitis or pneumonia. What is in this x-ray? So what is the distinctive feature you see in this x-ray? Again, there is a mediastinal shift. Everything is shifted to left side. But what is causing that shift? There is a hyperlucent shadow on the right side. So there is hyperlucency. You cannot see any bronchovascular markings here, right? So this is a hyperlucency on the right side, which is causing a shift of mediastinum to the left side. So there is air collection. So this is pneumothorax. And what is this opacity? This wedge type opacity is the collapsed lung, because there is air accumulation in the pleura. Again, what is there in this x-ray? So again, hyperlucency as well as opacity. So there is opacity, homogeneous opacity, as well as hyperlucency. But what is characteristic is this straight line. This straight line is suggestive of air fluid level. So if in any cavity there is both air and fluid, you will see these air fluid levels, right? So hyperlucency on the left side, mediastinum is shifted toward the right side. You can see the trachea is going toward the right side, the heart has shifted toward the right side, right? And you can see an air fluid level. It means there is both pus or fluid as well as air. So it is called hydropneumothorax. This patient has left-sided hydropneumothorax. So this is slightly difficult. Take your time. You can pause the video. So what is there in this X-ray? Again, yes, mediastinum is shifted towards the right side. So whole of the cardiac structure you can see is going to the right side. Trachea is towards the right side. What is there in the X-rays? How will you describe these? So these are cystic in nature, right? So cystic lucencies, multiple cystic lucencies. So multiple cystic hyperlucent lesion on the left side occupying complete left hemithorax and with shift of mediastinum to the right side. And these cystic lucencies, if you see, they are continuous with the bowel loops. So these are nothing but the bowel loops which have herniated into the left hemithorax. So this is nothing but diaphragmatic hernia. Obviously, when it occurs in neonate, we call it congenital diaphragmatic hernia. So again, in this X-ray, you can see this patient is intubated. There is an ET tube. There is an OG tube in situ. The bowel loops have herniated into the left hemithorax. So what this condition, if there is a rent in the diaphragm and your bowel loops, and depending upon the degree of the rent, even the spleen or the liver may herniate into the left hemithorax, which will cause compression of the ipsilateral lung. So this lung will be underdeveloped and the mediastinum will be shifted towards the opposite side. Okay, so what is in this X-ray? So again, you cannot say opacity, right? So this X-ray has haziness. There is a diffuse haziness of the bilateral lung field. So diffuse haziness, bilateral lung fields. So this kind of haziness we call ground glass opacity, and it is very typically seen in the respiratory distress syndrome or RDS, also called hyaline membrane disease. What is in this X-ray? So this X-ray has multiple tiny nodules, right? Multiple tiny nodules widespread across bilateral lung fields. So tiny nodular opacities in bilateral lung fields. These are called miliary shadows. So this is most commonly seen in miliary TB. Most commonly, not always, right? So there are other differentials also for these miliary lesions. So mostly tuberculosis, but even histoplasmosis, blastomycosis, coccidioidomycosis, they can also give rise to miliary nodules. Metastasis from various sort of malignancies can also give rise to such shadows, and even the diseases like sarcoidosis, silicosis, hemosiderosis can also. You can take a screenshot of this because this is a very commonly asked question whenever you are shown an X-ray of miliary TB. What is in this X-ray? What appears to be abnormal? So you can pause the video, take your time. So somebody may think that may be apparent mediastinal widening, but again it's an infantile X-ray, so this is nothing but the thymic shadow. So 1, 2, 3, 4, 5. So not an expiratory film. 5 to 7 is okay with us. What is abnormal in this X-ray is the bone fracture, right? So there is a left clavicular fracture is there. So we have to pay attention to the bone also, right? Similarly, look at this X-ray. What is abnormal in this X-ray? So the trachea is midline, lung fields appears to be okay, penetration is okay, there is no rotation. So what is abnormal? Air under diaphragm. On the right side, we should not have seen this crescentic air collection, right? On the left side, sometimes we see air because of the gastric bubble, but that is not crescentic in shape. So if you are seeing this crescentic air collection under the diaphragm, it's an ominous sign, suggests intestinal perforation. So here is a pro tip for all of you. If you are shown a chest X-ray by your examiner and it appears normal to you, then always look at bones and under the diaphragm. So friend, this is all for this video. We have learned about how to read chest X-ray and we have learned commonly shown X-rays to us. But in the next video, we will talk about more radiological aspect, more radiologically important images which are being kept in examination apart from chest X-rays, right? Thank you for watching and you can subscribe our channel for more such interesting videos. Thank you.